All right, hello everyone and welcome. We are so glad that you have joined us today. My name is Gary Parker. I'm the Associate Dean for External Affairs and the Director of the Clark Fox Policy Institute. And you've joined us at a series we're calling Open Classroom. It's a way for the Brown School to open its virtual doors and allow the community in which we have such a strong tie to come and join us for a little professional development, learning some new skills, or even just kind of learning about a topic that you may not know too much about, or as if you were listening before, you may have even heard some of what we're going to talk about today, but we always think that reinforcement of information is a worthwhile and important thing. I want to thank Janet Gillow and the Office of Professional Development for really pulling all of these together. As you know, there's a series of these, 2, sometimes 3 a week. So I encourage you to keep checking back to that registration page because we will have additional open classrooms. I want to just briefly mention one on Tuesday, April 28th at 10 a.m. We will be doing a webinar called COVID-19 and Race, the Disproportionate Impact on the Health of Communities of Color. And we have Angela Fleming Brown, who is the CEO of the Regional Health Commission. We have Jason Purnell, who's a faculty here at the Brown School and also is chairing the regional response team for COVID here in the St. Louis region. We have Dr. Sean Joe, who directs the Homegrown Project, and we're still working on 1 or 2 others, and that'll be moderated by Cynthia Williams, who's our Assistant Dean of Community Partnerships. So if you're interested in that, again, go to that professional development page. There'll be opportunities to sign up for that there, and then we'll send you that program information the morning of. And today, somewhat related to that topic as well, we're going to be hearing about class and equity in healthcare. And for that, we have Vetta Thompson. She is clearly a favorite amongst our students and alum. She is the E. Desmond Lee Professor of Racial and Ethnic Diversity. She's also our Associate Dean for Diversity, Inclusion, and Equity. And she's the co-director of the Center of Community Health Partnerships and Research at the Institute for Public Health right here at Washington University. So let's please give a nice, warm Brown School welcome to Vetta Thompson.
Okay, good afternoon, everyone. I have to begin by saying that I hope that all of you have been social distancing and remaining safe and well. I know that the length of our social distancing effort has been a bit trying, but I think we are seeing the positive effects. So thank you all for that. And then thank you all for joining me. I know that by this time, Zoom calls are not the favorite activity of the day. They are no longer the novelty that they once were. And so I'm going to try to keep this lively and conversational so that you are awake and engaged. If you have questions, please feel free to put them in the chat. I've asked Janet and Gary to check and maybe every 15 minutes, signal me that they have questions that they want to get in, and I will try to answer 2 to 3 of those and then keep going. And if we don't get to all the questions you have, I am easily found on the Brown School website. Email me, and typically within 24 to 48 hours, I will respond and answer your question. Also, as some of you heard at the beginning, I provided Janet with resources for you. There is a link to the CLAS Standards Practical Guide. Is a shorter version of the guide that I prefer, which is called the Blueprint. But to access the Blueprint, you have to go to the website. So I provided that link. You register. It's free. They don't bug you with a lot of emails, but it's a great site because they're constantly updating. There are so many training materials that you can access for free. So I encourage you to do that, and you can download the copy of the Blueprint, which I study religiously as much as I look at it, I'm always finding new things in there that are helpful. And so with that, what I want to try to do very quickly today, this is some of you who've worked with me on projects in the past know that I've done lectures on this that have lasted the entire day. But in 1 hour, I'm going to take you through the short version of the CLAS standards. I'm going to provide a bit of the context for the Enhanced CLAS standards. I'm going to review the actual standards themselves, and then I'm going to talk about how we use the CLAS standards to achieve health equity. And so to begin the discussion, we have to start where this nation was stuck for a while. We talked about disparities. And we see disparities in all sorts of outcomes: educational, income, employment, judicial. We've discussed all of these. And in the last in the last decade and a half, 15 years, we've had a lot of discussions around health disparities and health care disparities. One of the pieces that sort of brought this really to the forefront was a book that was prepared by the National Academies called Unequal Treatment. And then people saw the video series Unnatural Causes. But these differences, whether they're in education or health, are symptoms of a problem that has a common root cause. And most of this begins in a history and is rooted in a history of oppression. But now just talking about this and acknowledging disparities and the factors that produce them does not lead to solutions. But I think it's important to state that at the outset because it does set the context for the discussion that we're going to have. The other thing that I always say to people is that our acknowledgement of disparities is not new. Disparities have been discussed since the 1920s by scholars such as W.E.B. Du Bois and E. Franklin Frazier. Du Bois, a sociologist, actually began chronicling the health disparities in racial and ethnic communities, particularly the African-American community, in the 1920s and 30s. And so these are not new discussions. And I think sometimes we lose sight of history and we think that these are things that have just emerged or we are just gaining awareness of them. Luckily, we've begun to transition to terminology that is shared around the world. We spent a lot of time talking about health disparities when the rest of the world was discussing health equity. So what is health equity? Health equity is assuring that all members of our society have an opportunity for health. Health being broader than just not being sick, but health being a sense of well-being and the ability to lead a full and productive life. When we talk about these issues, it's not just about race and ethnicity, it's also about socioeconomic status, gender, sexual orientation, mental health status, and a host of other social factors that might contribute to inequity. And that's the reason that in many of these discussions, we actually talk about the intersectionality of all of these issues and how they come together and compound to produce the disparities and the inequities that we see. Now, it becomes important to understand what equity is and is not. So when we've moved to talking about health equity, the discussion really took off in the US when we were working on the Healthy People 2020 overarching goals. And I'm hoping everyone is aware of our Healthy People 2020 goals. But we've had many Healthy People goals. Most of the time we don't reach them. Many times we don't get very close, but they're aspirational and they help us to think about where we ought to be. And so for the Healthy People 2020 goals, they added some language that we had not seen when discussing health and health outcomes in the US. they added in the goal of achieving health equity. Now, to achieve health equity, we do have to eliminate disparities, but we lead with the acknowledgement that we have to go for equity in health. But we added a piece that many European scholars have been discussing for a very long time. The fact that so much of health is determined by factors that have nothing to do with access to health care or medicines we take, but they are determined by our access to the health producing factors in our social and physical environments. And so they added the line, create social and physical environments that promote good health for all. Meaning we have to look at our society and we have to look at where people can access things like healthy food, or can they access healthy food? What are the impediments to accessing healthy environments when they are in our communities? Is that due to transportation? Are the transportation barriers due to income? Income is a major factor in health outcomes. Poverty is a major predictor. Where we live, our zip code is a predictor because it tells us something about access to all of those social determinants that determine who will live a long and healthy life. So the question then becomes, if we have these goals, how do we close the gap between the health outcomes, the social outcomes, the educational, the judicial, all those disparities that I noted at the beginning? We have to reduce risk factors. So we have to understand what those are. We have to provide healthcare access. We have to provide access to those social determinants that produce health. We have to then, in order to achieve those things, we have to look at the policies that affect health and well-being. And one of the things that I think people in public health have become fond of saying, all policy is health policy. Because when we're talking about child welfare, when we're talking about nutrition and food access, when we're talking about healthy physical environments, the presence of parks, green spaces, the sidewalks that are well kept, that allow people to walk and traverse their neighborhoods, grocery stores in close proximity that allow people to access healthy food and fruits and vegetables. We are talking about health policy. When we talk about employment, when we talk about protections in the work environment, we are talking about health policy. When the nation undertook the effort to enact the ACA, everybody says Obamacare. I hate saying Obamacare, but for whatever reason, I'm blocking on the real name, but I might have had it right. But when that effort was undertook, there was an effort in the federal government to combine all of the health policies and to link, well, not combine them, but to link them so that they spoke with one voice on certain issues that we believe would improve the overall health of the nation. And the CLAS standards are one of these policy initiatives that was brought into line with that thinking. And that's the reason the Healthy People 2020 guidelines incorporate the social determinants and the language of health equity, and so do the CLAS standards. And so what are the CLAS standards? Anyone who was around in about the 2000s up until about 2010 was aware of the CLAS standards, which are the culturally and linguistically appropriate services. But the original CLAS standards were not structured as the current CLAS standards are. So the original CLAS standard was broken out into mandates, recommendations, and suggestions. Now, I often tease people and I say, if someone gives you a mandate, typically you're going to sit up, pay attention, and you'll probably do that. If someone gives you a recommendation, it's like, I'll get to it when I can afford it, when it seems reasonable. And people give you suggestions. If I want to do it, I will. And in general, those are things that are on the back burner so long that I forget about them. And that's a lot of what was going on with the class standards. The ones that were in mandates, you will hear about, I will talk about them as the cultural, the language and language access standards. But I think that was the reason they changed the names, because it was very clear in reviewing the impact that the standards had that they weren't having much of an effect. And so they scrapped the language around mandates, recommendations, and suggestions. And they created these 15 standards that instruct individuals and organizations on how to implement and maintain culturally and linguistically appropriate services. Because we see this as a step and a part of the framework to move toward equity. All 15 standards are believed necessary to advance health, health equity, and improve quality of health and health care, and eliminate healthcare disparities in our country. And so who is the class audience? A lot of times when I talk about this, organizations will ask me, well, I'm not a health organization. Do these apply to me? The class standards actually apply to all recipients of federal funding. And so if you receive federal funding, there is some expectation that you abide by these standards. That includes those accreditation and credentialing agencies and purchasers, community-based organizations who work in health or provide critical services and care, public health workforce and educators, the governance and leadership of entities and governing bodies that draft laws, regulations, contract language, health and healthcare service providers, the staff and administrators, as well as patients and consumers. The class audience is directed to consumers so that they understand their right to receive accessible and appropriate health and healthcare services, and they can evaluate whether providers can offer those to them or whether they are. But in order for the class standards to have their optimal effect, all parties have to not only hold themselves accountable, but they have to hold those that they work with accountable. So one of the things I say to every organization that I work with is that you have to look at not only what you're doing, but what are your subcontractors doing? What are your partners doing? And are they compliant? Increasingly, we find funders who ask people to abide by the class standards. Anyone who's had a SAMHSA grant any time in the last 5 years knows that they seriously ask for enforcement of these standards. But when I've been training, I've had the Agency for Healthcare Quality Research in the audience, and they ask that people be adherent as well. And actually, they provide an excellent resource. If you are interested in knowing where we stand on healthcare disparities from year to year, they produce one of the more substantive reviews of where we are in that area. And the Social Security Administration also is serious about this, to the point that if you are a provider of services or assessment for them, and you are unable to adhere to something like the language access services, if you call the offices, they can link you to the resources you need to be adherent to those standards. So the structure of the standards, the current version was issued in 2012. The principle, they consist of a principal standard, which I will go over, but this is the unifying standard for all of the other standards that follow. And it's believed that the remaining 14 standards will help achieve the principal standard. The standards are grouped based on governance, leadership, and workforce, and then the communication and language assistance standards that I've mentioned already. And then the final standards that I think are the most substantive, not the most, but they probably will take us further in terms of achieving equity and our ability to know where we are in that effort and when we're really making sustained progress, are those engagement, continuous improvement, and accountability standards. So the principal standard. And I say this every time I give this talk. If anyone quibbles or has some reaction to this standard that says, I don't think this is something I could abide by, I honestly think we have to ask ourselves, are we in the right business? Because the standard simply says we are to provide effective, equitable, understandable, respectful, quality care and services to all who enter our doors or through our doors. Everyone we serve is entitled to effective, equitable, understandable, and respectful quality care and services. Now, one thing I forgot to say that I do want to say, if you look at the training video provided by the Office of Minority Health, they make it clear that these standards, because they are about providers who do provide critical services as well, apply to police, fire, any first responding organization, those providing food access, so SNAP offices, WIC offices, any of those organizations, because those are critical, vital services that support the health and well-being of the community, they are subject to these as well. And if you watch the training videos, you'll see there are examples of how even those organizations are intended to respond to the standards. So standard one is the principal standard because it's our ultimate aim. And then as we adopt the remaining standards, we can achieve standard one, and that moves us toward health equity. So basically the principal standard is saying you have to, or you should have a safe and welcoming environment at every point of contact. So it's not just about the people providing direct services and care. It's about anyone in your sphere who comes in contact with the people you provide services to. Everyone should be able to help a patient, a family. It also says we ensure that all individuals receiving care and services experience culturally and linguistically appropriate encounters. People should not have to struggle to understand in a language that they're not versatile enough in to provide the level of information the provider needs in order to provide quality services. Nor should the provider have to struggle to understand and make guesses that might lead to them providing less than quality care. This requires that we meet communication needs so that individuals understand the health care and services, all of the services that they receive, so they can participate effectively in their own care and service receipt, and so that they can make informed decisions. With the goal of eliminating discrimination and disparities in the services that people receive. So hopefully in reviewing the principal standards, you're starting to see why this matters in our effort to achieve equity, and in particular health equity. So then we move to governance, leadership, and workforce. These three standards say that this is about the entire organization from top to bottom. Change begins with the leadership. And many times when we look at efforts, equity efforts, efforts to achieve culturally and linguistically appropriate services, a certain segment of the organization is selected and expected to train and to then implement and make sure that the organization is in compliance. And what we know is that doesn't work. So standard 2 says that there has to be an effort to advance and sustain organizational governance and leadership that promotes class and health equity through policy, practices, and allocated resources. The reality is we know that most providers don't have it within their scope of practice or work to implement the policies and practices and resources that guarantee that organization is going to have what it needs for everyone to be served as the standards require. That requires that the administration, those with leadership and governance responsibilities, assure that the policies are continuously reviewed, practices are reviewed and adjusted, and the resources are there to accommodate what the community you're serving needs. Standard 3 says you recruit, promote, and support a diverse governance, leadership, and workforce that is responsive to the population in the service area. This becomes important because one of the factors that we know play a part in inequities and the lack of resources for a healthy community environment are discrimination in workforce and employment and occupations that lead to lower incomes, fewer benefits, and undermine the health and well-being of a community. And if the organizations working in and serving in a community will not hire in that community, we know that that community is going to see those income gaps that fuel inequity. And so this says that if you are truly committed to this, you look for opportunities to train people, to support their educational efforts. You look for opportunities to bring diversity into your organization, and you promote that diversity so that diverse people are involved in key positions in your governance and administration. It is insufficient to have people employed, but they're all at the lowest level, or they're all stuck at the low and mid level, and there's no one in governance and leadership. And Standard 4 says you educate and train the governance, leadership, and workforce in the CLAS standards. Now, some organizations have permitted me to take a little step forward and also train members of the community that they serve. Some of their patient constituents have gone through the training. But again, our goal is for them to understand their rights and to have the ability to come to leadership and assert the fact that they have certain expectations for the care and services that they receive, and that they should receive those. And then we move to the communication and language assistance standards. Here there are 4 standards that apply. Standard 5 is the one we are most familiar with. It's been around the longest, and that is that organizations are required to offer communication and language assistance. Now, you will probably notice at some point in your career or in seeking services that many organizations that are expected to be in compliance are not in compliance. Many police departments that I encounter do not know that they do have an obligation to be able to call on a protocol that's in place to provide information, to communicate with people that they are engaging with in the community in the language that is their primary language and that they can understand. There are a number of ways to offer this assistance. It can be telephonic, it can be computer-based, you can have interpreters that you call who come to the scene. You can have bilingual staff. But if you have bilingual staff, Standard 7 applies, and I'll come to that. Standard 6 says that we have to not only offer this assistance, we have to inform individuals of the availability of language assistance. Now, when organizations have asked me to come in and do reviews for them, sometimes what I notice is they do offer it, and there's a note on their website, but it's somewhere in small print in a little corner, and you really have to look for it. To me, that's not true information for the individuals about availability. Websites are fine, but prominently displayed in the building, not in little corners, not in corridors that no one walks through, but in the corridors where people enter, clearly visible, and people know how to ask for and request the services that they need. But standard 7 is even more important because it says we have to ensure the competence of the individuals providing the language assistance, meaning that when we have materials translated, we have a responsibility to know who's translating, what's their training, what certifications do they hold, what process do they use for their translations to assure the accuracy of those translations. And then standard 8 says that we are to provide easy to understand materials and signage. Now, this is where the enhanced class standards have gone beyond the original standards, because standard 8 makes it clear that we're not just talking about foreign language access. We're saying that every individual, regardless of whether they speak English or a foreign language, should have materials that are translated or that are available in a way that is easy for any individual to understand. In English, that usually means we're looking for somewhere around 6th grade reading level. Materials should be assessed for whether they are plain language and easy to understand materials. This was one of the reasons there was an increased emphasis on health literacy in this country. We know that many times people enter into service centers and people are talking to them, providing them with information, and they walk away and understand very little of what they've been told about their rights, what services they're going to receive, what they have to do to receive those services, what they have to do to retain those services, where they can gain assistance if they need help in doing any of those things. And so specifically with hospitals and government offices, is there signage to help people get to the place they need to go to apply, to talk to someone, to obtain the assistance they need? Think about the last time you were in the hospital. When you see those signs that say cardiology, nephrology, neurology, do you have to go back to college classes? It's like, no, I know that this one probably links to something with the kidneys because I see the nephro in there, but that other one, I don't really know. You know, people shouldn't have to puzzle. It should be clear where the service is, the direction they're supposed to go, and what's being provided. So it's also about health literacy. And I think that's important to remember. But these also extend to those with sensory concerns. And so if a person has a lack of, is hard of hearing or deaf, there should be access to interpreters or telephonic ability to communicate that compensates. No, that's if they're visually impaired, the telephonic, so they can have the lines, the TTY lines. But if they're deaf, so that they need interpreters, sign language interpreters. The facility should have, be equipped so that they can do wayfinding if there's a need to. You'll notice in hospitals and on elevators, they have the Braille numbers for people who lack sight or are visually impaired. So all of those things are expected in order to be in compliance with the class standards. Now, one thing I have to say about the standards before I keep going, there is an understanding that organizations vary in size and in income. And so, and in the populations they serve. And so the standards are flexible. They say, if you are this size and you have this income, maybe it's better for you to use a web-based interpreter or translation service as opposed to having to call in-person interpreters. Perhaps you partner with a larger agency that has translated materials and they share with you as opposed to you trying to do everything on your own because you don't have that budget. There are ways to meet the standards without doing everything yourself. And I think that becomes even more important when we move to the next step. The point is that you are aware and you are planning and you're going through the guides in order to understand what's considered an acceptable way to engage in the effort to move forward, and to understand that there are few organizations that ever really reach full implementation. Most organizations are improving as they go. They start out with those beginning steps and then they get better. Now, in all of these communication and language assisted steps, they don't work if the staff and everyone in that building and in that organization who needs to know what to do doesn't get the training, doesn't know where the resources are, and can't access them when they need them. So I've done site visits and I've asked people for their language identification cards. It does not make sense if a person doesn't speak English to ask them in English what language they speak. I mean, that goes nowhere. And so you have the language access cards, but it doesn't help if the staff don't know where the language access cards are. And I've had times when the administrators knew where they were and had them, but the staff would say, I've never seen them, I don't know where they are. So that's one reason for the ongoing training. So everyone gets a refresher, everyone knows what the procedures are. Even if you can identify the language and you don't know where the resources or how to access the resources, that's not helpful to you. So constant training and updating, particularly if anything changes. And then the last set of standards are the engagement, continuous improvement, and accountability standards. Standard 9 says that class goals, policies, and management accountability have to be present throughout the organization's planning and operations, meaning that when you're doing strategic planning, you're talking about these issues. When you are doing yearly updates and reviewing where you are in your strategic plan and your organizational goals, that you are observing and you're looking at where you stand with respect to the class goals, policies, and management accountability processes. Standard 10 says in order to set those class goals, you need to conduct an organizational assessment. You need to know where you are. What are you doing? What are you doing well? What have you started, but you're clearly nowhere near where you ought to be? And where do you excel? Standard 11 says you got to know who you serve. And so it asks that people collect and maintain demographic data. And this is one of the reasons that I recommend people go to the Think Health website and access the blueprint. Because in the blueprint, you will find strategies for collecting and maintaining that demographic data. They give you the standards for demographic data collection and some ways to ask for that data. They provide you with language so that you can explain to people why you're asking for some of the demographic data that you may have to ask for, that people maybe say, what might make people suspicious, people might be reluctant to provide, but it allows you to explain why you do this and why it's going to be helpful, not only to you and the organization, but to them and the community at large. In conducting that organizational assessment and obtaining that demographic data, you are now able to plan and set your goals. It also says in Standard 12, conduct assessments of community health assets and needs. Now, I always tell people, in most communities, there are multiple organizations doing community assessments of health assets, as well as needs, and have all the demographics and information on barriers and resources in the community, community strengths, as well as community weaknesses. So the one thing I always say about Standard 12 is if the data exists within your region, use the data that exists within your region. Don't expend your precious resources collecting what others have already collected. if you know that you and others are going out to do that assessment at the same time, combine resources and everyone sharing the cost, that reduces your cost for that assessment and allows you to direct those resources to other areas of compliance that may be important to you. The other thing is with the demographic data, some of the demographic data that's more regional and not specific to your organization and who you serve, that's available through census data, and you can access that on your own through the internet, no to low cost. And so really here, it's not do everything as if you have to start from scratch. It's understand that you need this information for planning, but don't redo what's already been done. The most important part is standards 13, 14, and 15, because it asks you, as you're planning, partner with the community. Community input is vital. They can help you see your blind spots. What you're doing that you thought was helpful, that you thought was respectful, but for them, they may not experience it that way. They can also help you in setting goals that are more realistic, that the community is more receptive of, setting goals and providing services and using strategies that the community cannot or will not accept. Does that community no good? Does you no good? Standard 14 says create conflict and grievance resolution processes. This lets you get ahead of people feeling like you're not there for them, community members feeling like this organization does not really attempt to be a part of the community, doesn't attempt to strengthen the community, because they can share with you conflicts and grievances that are emerging when they feel that they're not being well treated, when they feel that they're not gaining what they need from the organization or the providers. And it gives you the opportunity to rectify that situation, to find solutions, and then to plan so that other clients, other people receiving services don't have those negative experiences. And then standard 15 is communicate. Communicate what your organization is doing. What progress are you making in implementing and sustaining the CLAS standards? That becomes important because it builds goodwill in the community. It allows people to give you feedback and it helps you grow. And as a part of that process, solicit community input. Input on your report and what they see of the progress you've made, what they think of your goals, how they think you should change or work through issues that you're having. All of these steps become important in the accountability phase. When you've set those goals, backwards. When you've set those goals for your policies and your practices in Standard 9, you now have the obligation to understand and to figure out, okay, how am I going to measure where I am? And what do I do if I'm falling short? So one of the things we talk about is having a group of people who are designated to receive all of these data, all of this information, the demographic data in your region, the demographic data on who you currently serve. So what you want to do is the people in your region and the people you serve, do you serve the people that you would expect to receive, that you would expect to serve given the demographics? And if you don't, why not? And a part of what you find out from community input is, why aren't they coming? Why don't they use your services? Why do people come and drop out? So a part of what you want to always look at here is, who am I serving? Am I serving those who are in my region? If not, why not? Are the people that I serve remaining in service until they reach their goals, their individual goals, for health or social or economic resources. If they come and they are not there for the time that they need to be there to get where they've said they want to be, what's going on? What's happening? And how do I change that? But then you've got to dig deeper. At this point, the standards call for disaggregation of data. And this is the most important thing that I will say today. Take that data and look at the disaggregated data. Are there parts of the community that I serve who do extremely well with my organization? They are adherent. They're there almost every session. They meet their goals. They report that they're healthier, happier, more productive in their lives. And then there are others who don't. The question is, for those who don't, what's going on? Why? What can we do differently? Constantly look at whether that has something to do with the composition of your provider or service workforce. Do you see differential outcomes depending on who that client is or that recipient is and who those providers are? Do those providers need more training or do they need more supports in terms of materials that are more health literate or materials that are language or culturally appropriate? Are people just having problems because of transportation? What can we do to address that issue? Is it because they have to juggle multiple appointments? Can our organization facilitate creating appointment schedules that work better with their work schedule or their lifestyle? So in disaggregating data, you learn more about what's keeping people from achieving their goals. And if you can work through that and help them to better achieve their goals, then they're able to be more productive and healthier and happier in the community and in the workforce. And in turn, adults can support that in children and adolescents. And we see an increase and an improvement in the health and well-being of the community as a whole. But we can't get to that when we don't disaggregate the data and understand what's happening for different segments of the community and the population. Are you seeing more complaints and grievances from certain segments of the community and population? It's all about the data, mining that data to understand what we need to do better and then holding ourselves accountable. There is so much more in these standards and about these standards that I could say, but I've been sneaking and monitoring the time, and I want to give you all time to ask some questions. So I'm going to stop for questions.
Great. Well, thank you so much, Vetta. This is incredibly informative. It seems that these, and I'm going to try and consolidate some of these questions. A lot of them are coming in. It seems like these standards are aspirational and that it would require a large influx of resources to many of the service providers. Can you talk about, other than additional resources, some of the obstacles that are keeping these from being fully attained?
I think that I don't see them as requiring huge influxes of resources. What it means is we need to be very strategic in the allocation of our resources, and we need to do some things that maybe we haven't done in the past. For example, collaboration. Coming together with similar organizations that need to do the same thing and collaborating on getting materials translated and sharing, doing needs assessments together, using common surveys to gather information rather than everyone building their own. Sometimes going in together and sharing evaluators who can do similar work for all of the organizations at cheaper cost because you're sharing that resource. But the other thing is organizations have to pay attention to where they are. You start somewhere. When I'm reviewing for organizations, I don't ask them to, particularly if they're in the middle of a strategic plan and the resource allocation plan has already been created. I try to help them figure out where they can leverage some resources to take those initial steps. For example, I have the language cards. What I have said to organizations, make a copy of this, go get it laminated. You may make several copies. Everyone knows where they are in a central location. Now they know where the identification cards are. Have another laminated card with the numbers that they call for the telephonic interpreter if they need it, or a website they can go to if they need it. Those are the lower cost options. And so for a small investment, you have now reached a standard. Training on the CLAS standards should not cost organizations huge amounts of money, which is why I provided that link to Think Health. There are videos for training. There are self-administered trainings online that people can do. I went back and did them myself to see what the quality was. Were there things to learn? And there are high quality training materials online that people can access for a variety of professions, and they are proliferating more and more material. So I advise organizations, if you can't make that investment to bring someone in, use what they provide online. And that's one of the reasons they have developed this website and that material, to reduce that cost. And then everyone in that organization can do it on their own. Maybe the administration and leadership commit to doing it on their own time, but they provide providers and others time at work to do segments or sections and incentivize that. So there are lots of ways, and the blueprint gives people guides for low-cost ways to do this.
Wonderful. We have a really great question from Cynthia, who asks, do CLAS standards emphasize that the governance, leadership, and workforce should reflect the community composition of which they are in or they serve?
That is why we have the standard that talks about recruiting, promoting, and supporting a diverse governance, leadership, and workforce that's responsive to the population in the service area. And a part of the self-assessment is looking at your boards, looking at your administration, looking at your staff, and the different level, your professional, your managerial, all portions of your staff, and what's the composition? And how does that compare to the demographic of the community, of the region? And where you see disparities and differences, asking that people go back and look for opportunities to hire, to recruit, to train. What can you do? How do you get involved with the educational system? For some organizations, that will be the first step, that they have a relationship so members of diverse communities may feel comfortable with them, may want to work with them, and they help create and build a pipeline to diversify the organization. But yes, the CLAS standards do recognize and call for that.
Rachel has a question that says, from what I recall, the ACA only requires that providers provide interpreter services for the top languages that are spoken in an area. Are the CLAS standards stricter? And if an organization doesn't have the funds to cover interpreter services for less common language, what is their resource?
If you look at the full guidance and the training videos, what they say is you have your strongest interpreter services for the top languages, but you also plan for ways to facilitate communication in less common languages. So you have to have a plan for what you're going to do, but in all likelihood, you're not doing what you do for the most common languages. So even if you can call an interpreter in for your, and the expectation, larger organizations, and you have a significant population speaking a language, yes, you should be able to call an interpreter in that situation. But if it's a much less common language, you would then, the expectation is you would know how to go to the telephonic or the web-based interpreter situation. So it's not absolving people of the responsibility for providing some reasonable access.
Another great question here. If we identify an organization in a personal or professional capacity that is not in compliance, what should we do?
I think the best approach that I have found is really working with people, coaxing them and coaching them, asking them if they're aware of the CLAS standards and sharing that with them, sharing the blueprint, sharing the website. But the other thing is, if this is a partner where you contract or subcontract, you know, you should have language, you should consider language in your contracts where you say, our expectation as an organization is that all of our partners are adherent to the CLAS standards or taking steps to become adherent to the CLAS standards at a minimum. And sometimes, you know, you can say at a minimum, we expect that all are able to provide training to their staff, language access, and have a organizational strategy for assessing next steps in improving their relationships with their services to populations of interest and concern to our region. Inviting people to attend lectures on this and other issues relevant to the CLAS standards. The other thing I have to say is when we talk about the CLAS standards, understand that with the training, when you read the guidance, they provide a list of training that organizations should undertake, not just training on the CLAS standards themselves, but other training that is relevant to providing quality, respectful care to all. So it's not just about hearing about these standards and what to do to achieve them. There are other components that are part of this. So that's the reason I said this is just the beginning.
Well, we are just about out of time, and I want to apologize that we weren't able to get to all of the questions. But I wanted to offer you an opportunity to make some closing remarks, and then we'll hand it over to Janet to wrap us up.
You know, I don't want anyone to walk away feeling overwhelmed. What I encourage people to do, take a look at the practical guide, see where you think you are, and pick one or two first steps in each of the domains: workforce and governance, language access and assistance, and then the accountability and engagement and continuous improvement standards. They call them continuous improvement for a reason. We know where we are. We know where we want to be. There's a long path to get there, but every path following a path starts with taking that first step. Take the first step.
Thank you so much for that, Vetta. Appreciate everybody being with us today for Open Classroom. I want to bring to everyone's attention that we are back on Thursday with a great program on growth and equity in the St. Louis region presented by Executive Vice Chancellor Hank Weber. That program is actually full at this time, but we will be streaming on YouTube. So encourage everybody to check that out. And this was mentioned in the chat, but I just want to remind folks that Dr. Cinder Thompson's slides are going to be sent to you, along with a PDF toolkit and a link to the toolkit that was referenced throughout. So we certainly want to put those in your hands so you can follow up on this great information. Thank you all for being with us. Thank you, Vetta. This was really informative and so helpful. And stay healthy and safe, everybody. We hope to see you soon. Bye now.